for an hour and a half, but I'm not going to talk for an hour and a half, so we should have plenty of time for questions. And into a conflict of disclosure of conflict, I don't believe I have any conflict related to this topic. I actually do not derive any income except for my clinical and academic jobs. There's a slide here. We'll now observe a moment of silently checking our BlackBerry. So I've turned mine off, so that's a reminder for people, particularly when they're a large audience. And the objective of this lecture, I want to kind of cover three things. To review the role of depression as a risk factor for dementia, then to discuss briefly the difference between dementia and depression in older person presenting with depressive symptoms, and then to discuss briefly the role of antidepressant for patients suffering from both a dementia and a depression. Before I start there, it would be useful for me to know a little bit more about the audience. So who of you in this room would define yourself as clinician? Nurses, physicians, social worker? So half of the room. And the other people who are not clinician, what do you do?
Teach. I have been a teacher.
Teacher, sociologist, and public health? No? Okay, so, but most of you in the room are clinicians. So I assume that most of you come with, and I assume most of you are interested in aging. So I assume most of you have an understanding of what dementia is and depression is. And I'm not going to go back, but I'm going to talk about really all those two interface. So in one of my presentations of this topic, I was asked to create questions before and after. So you're going to see the same question at the end of the lecture. If I've been successful, you should have a better idea of what to answer them. So imagine you have a population-based sample. History of early onset depression increased the likelihood of dementia diagnosis more than threefold. Is that true, or is it false, or does it depend? Okay? And those of you who are here and have a problem seeing the slide, there are plenty of seats there, by the way. We don't encourage you to move rather than crane your neck. So do you believe that if you see somebody who presents and that person is 72, that person tells you that in their 30s, you know, after having a baby, they were depressed for 3 months and they had to be hospitalized, and then they took a year to recover. Do you believe that person is at higher risk of dementia than somebody who doesn't have that history? So that's the question. And then, if you have somebody presenting with some depressive and cognitive symptom, an older person, do you believe that which of those tests do you think would be most useful to try to distinguish what's what? Neuropsychological testing done by a PhD psychologist, a PET scanner with looking at glucose metabolism in the brain, trying to treat the person with an antidepressant to see if they respond, and if indeed it was depression, and if they don't respond, the symptoms stay, you would think they are dementia, or just watching them over time to see what happens. So those are the two questions. So why do we even have a lecture like this? Because as you can see, there are a series of epidemiologic studies that have found that there is a fairly large overlap between dementing disease and clinical depression. So when people look at a population of patients with Alzheimer's disease, they find that cross-sectionally about 20% of them will have clinically significant depressive symptoms. If you look at a population of patients who have had a stroke, it's the same 20%. Huntington disease, it's closer than 40%. People with Parkinson's disease, it's 4%, 50%. And the general population is 4%. So just looking at epidemiologic study, you can see that you are between 5 to 10-fold more likely to have a clinical depression if you have one of those neurologic conditions that present clinically as a dementia syndrome. So now when we talk about the relationship between depressive syndrome, so depression and the depressive syndrome, we talk for instance of a major depressive episode. It's characterized by sadness or lack of interest, problem with sleep, problem with appetite, low energy, hopelessness, suicidal ideation, difficulty making decisions, cognitive issues. So those are the core symptoms of depression. So when you present with those symptoms, what does it tell? What's the relationship with dementia? So and I'm going to discuss depression as a risk factor for dementia. So is it a risk factor when you have a depression in your 30s to have a dementia 40 years later? Is it a risk factor when you're 75 and you present with a depression to then have a dementia within the next few years? Depression as a prodrome, so somebody present with depressive symptoms, but they say their sleep is poorly, their eating has changed, they sit in a chair all day, they don't seem to be enjoying anything, they cannot make decisions. Is that a depression, or is that actually dementia symptoms that are presenting initially as dementia symptoms that are presenting as depressive symptoms? And finally, in somebody with Alzheimer's disease, well established, they have Alzheimer's disease for the past couple of years, so they have been confused, they have been unable now to pay their checks, their bills, they are getting lost when they try to go from their home to their daughter's home a few blocks away, but that person starts to develop symptoms of problem with sleep appetite, crying, making very hopeless comments, let me die. Is that a depression or is that the dementia disease? So that's what we are going to discuss. So first, the issue that is the most surprising to people is when they hear that some studies show that early onset depression, having a depression in your 20s or your 30s, even if you get treated, even if you are never depressed again, put you at risk for dementia, or more specifically Alzheimer's disease, 30, 40, 50 years later. So what's the evidence? I'm not going to show you everything. I'm going to show you a series of, for all those questions of paper or studies that have addressed that question and are representative of many other similar studies. So, for instance, here you have a paper published a few years ago that look at the likelihood of a diagnosis of dementia in a population, and they find that people who have an history of depression within the past 10 years are 4 times more likely to meet criteria for diagnosis of dementia in the general population than people who don't. And in that study, having a history of depression more than 10 years ago gives you actually no risk. It's a risk of almost 1, which means no difference. And they find that the depression is a risk factor for dementia, but when it's recent. And as you go back in time, you actually decrease the risk. So in that study, they tell you, if you're an older person and you develop a depression, you are likely to have a dementia to meet criteria for more likely to meet the criteria for dementia during the next 10 years. If the depression is early in your life, it's not a risk. So that's this study. And then you have a study like this one, which find that history of an early onset depression, okay, another population-based study done in Rotterdam, a famous aging study there. They looked at people who had a depression in their 40s, 50s, 30s, and they say when those people present in their study in their 70s and 80s, they find that that past history of depression triple their chance of meeting criteria for dementia. And they say if you have a late onset depression, if you have never been depressed in your life, you get depressed in your 60s, your 70s, you double your risk of dementia during the following year. So they find that both early onset and late onset depression are a risk factor for dementia. But actually in this one, the risk is higher for early onset depression. And they find that if somebody present with current depressive symptoms, they have a 30 to 40% chance, higher chance to meet criteria for dementia than the general population, but it's not that through a risk. And in this one, they also start to look at mechanism. They look at the brain of their subject through imaging, and they say the risk doesn't seem to be linked by shrinkage of structure in the brain that are involved in memory, like the hippocampus or the amygdala. So that's you see, very different result from the previous study. When you look at the overall, okay, so you have study on both sides. Overall, if you did a meta-analysis of all those studies, the evidence at this point, if somebody asks me, somebody is 30-year-old or 40-year-old, and they say, I've heard that it puts me at increased risk for Alzheimer's disease 30, 40 years down the line, is that true? I will tell them, yes, the majority of studies find that a depression early in life between, double or triple your chance of dementia 40 or 50 years later. So that's That would be my response based on the literature, but as you can see, I've shown you studies on both sides of the fence. So, by the way, if it's true, okay, then what is the mechanism? What can we do about it? Why would having a depression when you go through a divorce in your 30s, or when you have a baby, or what would it do to your brain to put you at risk for dementia 40 or 50 years later? And so there are people who have looked at possible mechanism, and the most popular explanation is depression is equivalent to a chronic state of stress. So when you're depressed, you have an hormone involved in stress response, cortisol, and you have a tone. It's not as if you suddenly become cushingoid, as if you were taking corticosteroid, but over time, you know, your tone of cortisol secretion is higher than it would be without a depression. So that the same way when you get stressed, you get an increase in cortisol secretion. You may remember in the 80s, people had invented a biological test for depression, which was called the dexamethasone suppression test. When you give dexamethasone, which is a very powerful corticosteroid, in a normal, healthy person, you block the production of cortisol in your body mediated through the brain, telling your adrenal glands to secrete cortisol. So that the cortisol suppression test was giving the dexamethasone suppression test, DST. You gave a pill of dexamethasone to people, and 12 hours later you measure their cortisol. In normal people, it should be at 0. What they found is in depressed people, they didn't suppress. They kept secreting cortisol. And in normal versus depression, you could perfectly classify the depressed versus the normal, and people say we finally have a very simple biologic blood test to decide who is depressed, who is not. The reason the test didn't survive clinically is because then people started to say, fine, but usually the problem is not to compare somebody who is perfectly normal and say they're perfectly fine, somebody who come to tell us with typical depressive symptoms and say they are sick, and they don't sleep, and they don't eat, and they want to kill themselves. That's not the clinical issue. The clinical issue is you have somebody who is a drinker and has some depressive symptom. Is it depression? Is it alcoholism? Or you have somebody with cancer who present with they don't sleep, but maybe it's because they're in chronic pain. They are losing weight, but maybe it's a cancer. They are not feeling like doing anything, and they stay in bed all day, but maybe it's the side effect of the chemotherapy. So how do we know if it's a depression? When you do the dexamethasone suppression test in all those people, the people with substance abuse, the people with chronic physical illness, they don't suppress either. But so that test was lost, but the basis, the biological basis survive in the fact that people who are depressed in their 20s, their 30s, or their 60s have too much cortisol 24 hours a day. They lose that kind of diurnal variation. They lose the suppression. It's a state of chronic stress. And what cortisol does to your brain, it shrinks your hippocampus and your amygdala, which are structures that are involved in memory. And so if you damage those memory structures in your brain, it's not that surprising that 30 years later, once you have other factors that put you at risk for dementia, you get your dementia onset earlier. And that's part of the explanation, and the studies that have looked at this have looked at people, the brain of people with past history of depression, who are not currently depressed versus the brain of people without past history. And now with MRI, we can measure those structures enough that you can show that the volume in people who have had a depression in the past is smaller, and there is even a dose-response relationship. If you kind of, through the history, estimate the time that people spend in their depression. So I was depressed 3 times in my life, when I was 20 and I was in college, and I dragged myself through an entire year in college. So I was depressed for 1 year until I recovered. I had my second depression when I had my baby. I was depressed for 6 months. I couldn't really take care of him, and then I recovered. And my third depression was when my husband divorced. This time I went to see a psychiatrist. I was started an antidepressant. The depression started 2 months. So you measure the number of months somebody spent in depression, and you come to that estimate. So you may have people who have been depressed 6 times, but each time were treated quickly. So there is only 12 months of depression. Somebody who had 2 depression, but not treated, each lasting a couple of years, 4 years of their life, and you find that those respond. The longer the time you spend in a depressive state, the more likely you have to have those structures in your brain which are shrunk. Cortisol could also damage other circuit and pathway, so that's the glucocorticoid explanation. Depression damage your brain through secretion of inappropriate secretion of glucocorticoid. Another explanation for a possible mechanism is that there may be other disease that cause both depression early in life and dementia later in life. And if that's the case, having a past history of depression in your 30s or in your 40s is simply a marker that you have that risk factor which is going to cause a dementia in your 70s and your 80s. So it could be, for instance, genetics. You could have some gene that puts you at risk for being depressed early in life and being demented. People have looked at it with the ApoE, which is a risk factor for Alzheimer, one of the strongest genetic risk factors. It's not a risk factor for depression early in life. So there may be some gene yet to be identified. There are other things that can cause depression early in life and could cause dementia later in life. And when I created that lecture a few years ago, there was not as much interest, but I've been giving lecture for the past 20 years and said to people, so I was in the US, in Western Pennsylvania around Pittsburgh, and I was saying to people, I would not want my kids to be involved in American football and to be repetitively hit on the head, which is very popular in Western Pennsylvania. Every high school, the glory is to be the quarterback, and there's the jock and the nerds and everybody, and all the young girl want to go with the football player. And I say, well, my kids is going to be golf or baseball, or I don't want him to be hit on the head. And then I moved to Canada, and I said to people, I don't want, now I live here and I have 3 kids going here, my kids do not play hockey, and I've done nothing to encourage them. I've actually, in a passive way, I've discouraged them. So they skate like every Canadian kids, but they don't play hockey because I don't want neither my boy nor my girls to be hit on the head. It's bad for you. And people thought that was, and the argument why it's bad for you is we have known this for more than 50 years. There is something called dementia pugilistica, which was observed in boxers. Okay, so people who box, and doesn't matter if they are the professional. By the way, tend to, if you're the famous professional, tend to be good. They tend to beat other people, and they tend to be not beaten on their head too much. So the famous champion tend to do okay. But the one who are not that good or who do it as amateur get multiple concussions. They are not that good at defending themselves. They are not that good at knocking down their opponents. So they get hit on the head repetitively. And what people had noticed in the 1940s and 50s is that those men who had been engaged in boxing in their 20s and 30s got demented, punch drunk, it's what's called. They got demented in their 40s and 50s. So that was, as I say, up to a few years ago when I was talking about those things, people thought I was a kind of a Martian and like one of those odd professors with those odd thoughts, and they would encourage their kid to go for the football team or the hockey team. Well, now suddenly, at least in Canada, there's an enormous interest about the relationship with concussion / a closed head injury and neuropsychiatric symptoms. And we are hearing 2 things. We're hearing that young men who are playing hockey and get hit on the head repetitively end up actually developing depression and suicidality, and there have been those high-profile suicides among those professionals. And we're hearing that the ones who don't get depressed necessarily in their 30s and 40s present in their 40s and 50s with dementia, and when people look at their brain, they have some specific neuropathology with dementia. So that's a mechanism, that's an example of a toxic cause that would cause depression early in life. If the depression is identified and treated, the same mechanism, once you have that mechanism, that pathology in your brain, you will present with dementia later in life. That's not going to explain the epidemiologic finding in the entire population, but that's an example of a mechanism, something that could cause depression early, dementia late. If you do it by history in an epidemiologic study, you're going to find an association between depression, early depression and late dementia. And then there are other possible causes. For instance, you know, when we think of Alzheimer's disease, we think people in their 70s, 80s, 90s, but the reality is the pathology, those plaques and tangles, the amyloid deposits start in your brain in your 40s and 50s. If I was killed in a car accident on my way out of here and people did a brain autopsy, I already have some plaque and tangles in my brain. So I have some Alzheimer's pathology in my brain. I don't have Alzheimer's dementia because, you know, it's what people have called the Swiss cheese model of Alzheimer's disease. So you have that pathology that starts in your 40s and 50s, and you start destroying little part of your brain. If you have enough brain reserve, you can go on for a long time, and that's why there are protective factors like education. If you have a nicer, better brain, more connection, your brain can endure more of those disruptions until your brain dysfunction to the level where we can diagnose the dementia. My memory is clearly not as good as it was when I was in my 20s, but it's probably still better. I remember, you know, as a clinician in a geriatric clinic, seeing a guy who was a retired professor of economics at Harvard. And so he come and he complained, he said, my brain is not functioning, there's something wrong. We send him to a neuropsychologist, he does an IQ test, the IQ comes at 125. You know, they say, well, look, you're still more intelligent than 70% of people. They say, you don't understand, my IQ used to be in the 140s, 150, I've lost 20 points. And he was right, by the way. We followed him, and because of that brain reserve, he was able to continue longer than the average person, that the retired steel workers that would present with the same pathology. But at some point, the disease caught on, and he developed the full symptom of dementia. So there may be, there is that question, can the early pathology in your brain, in your 40s and 50s, disrupt some circuitry that puts you at risk for depression? You treat the depression, but the pathology continues to progress, and 20, 30 years later creates Alzheimer's disease. So shifting gear now and talking about what about the late onset depression? Remember the first study saying if you have depression in your 30s, you're not really at risk, but if you have depression within the past 10 years, clearly you're at higher risk. So to which extent is it then a mechanism, or to which extent is it simply a prodrome? So somebody who is not genetically predetermined to be depressed, doesn't face a major stressor in his or her life that put them at risk for depression, but suddenly, so no family history of depression, no personal history of depression, no reason between quote to be depressed, but suddenly you present in your 60s or 70s with depressive syndrome. It looked like depression to a clinician like me, but maybe actually once we treat the depression, we unmask an underlying dementia. And so what's the evidence? So that's a line of research that has been pursued for more than 20 years with some fairly convincing evidence. So one famous paper by a guy at Cornell called George Alexopoulos, who is now a very distinguished senior professor, a paper he published early in the American Journal of Psychiatry, was to look at people who presented in his geriatric clinic with depression. And he classified them in two groups. One group that presented with depression without cognitive impairment, and one group with cognitive impairment. And the cognitive impairment was a very crude measure, the mini mental state examination, so people who were below the normal or people who were in the normal range. And then he treated those people with antidepressant, all of them, and he looked only at people whose depression resolved completely. So there is no depression, and he followed them for 60 months, so up to 5 years. And when he follows the people with the solid line who presented with, and those people are in their late 60s, 70s, early 80s. So when he followed them for up to 5 years, he finds that by and large, the majority of people who had depression without cognitive impairment, 70% of them do not meet criteria for dementia during the next 6 years. And even then, you see, there's almost no movement during 3 years, and then you start to have some people crossing the threshold, which is not that, if you think you're people in your 80s, 80 you're not demented, 83 you're demented. On the other hand, when you follow the people who presented with reversible cognitive impairment, and you follow them for 4 years, you find that almost all of them, 90% of them, during those 4 years of follow-up, will meet criteria for dementia. So that's where people start. it's not really depression, it's depression as a prodrome for dementia. And then there are other studies, for instance, with my colleague in Pittsburgh, where we have conducted for several years a follow-up of a cohort of older people. So we have both control and people who present with depression. Again, we look at depression which is treated successfully, and you can see that again over 5 years, it's very similar. We have up to 50% of people with depression who then will, late life depression, will then develop dementia, and then with people who are the controls who have a slower onset of dementia. And those people are older. They are typically in their late 70s and their 80s. So you're talking, in that population, if you see somebody who's 80, you follow them for 5 years, you can see the control 20-30% incidence of dementia is not that surprising, but it's almost double, and for the people with depression. So again, studies. So if you have a history of depression in the past, double your rate in this study, double your rate of Alzheimer's disease. So specifically, if you present to that study with a history of depression within 1 year, you multiply your chance, you increase your risk almost 5-fold. And if the depression is 25 years ago, it's about 70% higher chance. So again, the study you say you see both. So actually both end up being true, and that's why in different studies you find different things. Early depression increases your chance of dementia. More recent depression increases your chance of dementia, probably through different mechanisms. And the more recent depression is probably a higher risk than the remote depression. So now people have, as I said, there are a lot of studies. If you're interested in that topic and you do a search, you will find probably more than 100 relevant studies where people look at dementia in people with past history of depression, or they look at history of depression in people with dementia. You find that there is probably a dose response. So the more severe cases of depression are associated with incidence of dementia, the more benign cases are less likely. So when you have a dose response, by the way, as a clinician or somebody who believes in biology, those responses tell you that you're seeing something real. There are some phenomena biologically where there's a threshold function and it's on and off, but most, if something is bad, more of it should be worse. So another evidence for dose response, each additional depressive symptom has been line increase the risk of cognitive decline by 5% over the next 5 years. So you have a list of 9 possible depressive symptoms, you count them, the guy who presents with 2 depressive symptoms has a lower risk of dementia than the person who presents with 7. Okay? And here they're able to quantify it. Those models now have enough subjects that they can come up with fairly quantitative prediction. So if late onset depression is a prodrome of dementia or Alzheimer's disease, again, what is the mechanism? By the way, if you look, the estimate is that about 30% of people who will at some point have clear-cut Alzheimer's disease present initially before they have the typical cognitive symptom of Alzheimer's disease with typical symptom of depression. When you put it all together, that's the number I would cite in a lecture like this or to students. So what is the mechanism? Why is that so high? And again, there are various mechanisms that have been hypothesized. So one that was early, you remember I showed you the study done in the late 80s and early 90s, psychoanalysts at that time still were influencing the field. So their explanation was it's a kind of reaction for subcognitive decline. So they say people are struggling cognitively, they realize it's unconscious, but it expresses itself as a grieving type of depression. They are grieving for the loss of the self and the fact that they are slowly dissolving in depression. Very attractive, but actually not supported by most of the clinical studies, because actually, as we'll discuss, one of the hallmarks of dementia is that people have no insight on their dementia or not. There are a few patients that sticks out because they're like that Harvard professor who is bothered by his IQ of 125 and feel his mind is not working, but it's the exception rather than the rule. The typical patient with Alzheimer's disease at some point is brought up by concerned family member or neighbor or police or social services, and you ask the person, you know, what's the month, August, what's the season, winter, you point out, you know, since I retire, I don't really worry about those things anymore. So not at all bothered by, you know, you have the daughter crying in the room if she's listening and realizing that that there is something really wrong with her mother. The daughter may have been unconsciously knowing and have been suppressing and get upset when you kind of force the diagnosis on them. But the patient doesn't seem to be bothered at all. That's the typical patient. So that explanation of depression as a grieving reaction for the loss of the self because of subclinical cognitive decline that the person is aware of unconsciously is a possibility, but probably doesn't explain the vast majority of the case. So there are a lot of data, and I didn't show them to you, but that depression causes cognitive impairment. And therefore, if you have anything that causes cognitive impairment, it's going to lowering the threshold. You know, again, think of my Swiss cheese. You have a certain cognitive resource that's left. You get a cold or urinary infection, and suddenly the person appears very confused because, you know, so think of it, you know, if I the old blackboard, and think of it, you start with 100 points. When you go below 40 points, you have a clinically apparent dementia. You have now lost enough of your brain, and you are at 50. Okay? So you get a urinary infection, that makes you lose 15 points. You go from 50 to 35. You are that person in the hospital that look utterly confused, and people say there is something wrong with their brain. That's what we call delirium. You treat them with antibiotics. They go back to between, quote, normal. They go home. You follow them for a couple of years. They are going to get. They are going to then appear to have a dementia. Same thing, by the way, for the person who doesn't sleep very well. Go buy over-the-counter sleeping pill that you or I could take, and maybe we feel a little bit groggy in the morning. They're terrible. Those over-the-counter sleeping pills, all based on Benadryl, diphenhydramine, strong antihistaminergic and anticholinergic drug, cause confusion in older people. So younger people, you feel groggy, you don't pay attention. The older person is going to be clearly confused. Oh my God, it's Alzheimer's disease. You stop the inappropriate medication, they appear normal again. But what you have done is you have unmasked that they're on their way. So depression can do the same thing. Depression in older people cause cognitive impairment. They are close to crossing the line, but nobody believes they are demented. You have the depression. You take some of that cognitive processing capacity away. Now they meet criteria for dementia. You treat the depression, they appear normal. You follow them. The disease keeps progressing. A year later, they are demented, and that explains a lot of your epidemiologic findings. Cerebrovascular pathology, okay, you know that you remember the nun studies. Everybody in this room familiar with the nun studies? So most of you, you know those old order, actually. It's called the nun study. It has a more complicated name, the old order of whatever, that Snowdon in the US enrolled those nuns, followed them, got their brain. And so had a lot of finding, and one of the findings that's probably now 15, 20-year-old is that you know, people were trying to distinguish vascular dementia versus Alzheimer's disease. What he said, there are very few people, unless you have really a major stroke, that are going to get demented from having a vascular injury in their brain. But if you have all those small vascular injury, you know, go back to that Swiss cheese, they poke also damage in your brain. Then you have the Alzheimer's pathological process, and you get your dementia sooner, earlier. So here, it's again, the vascular disease takes some of your cognitive reserve, and therefore you have less left. It's like being banged on the head repetitively, and therefore you're going to get your dementia sooner, earlier. And remember, when we talk of dementia, most human beings are going to have some amyloid deposit in their brain. But if I'm slaughtered, if my slope of progression, my cognitive reserve is such that I'm slaughtered to get my Alzheimer, you know, I have Alzheimer pathology in my brain. But if I'm slaughtered to meet criteria for Alzheimer dementia, when I reach the age of 85, and if I die at 82 from a prostate cancer or lung cancer or heart attack, I will never have Alzheimer's disease. If I'm slaughtered to have it at 78, I will spend the last 4 or 5 years of my life with Alzheimer's disease. So when we talk of dementia, the process exists in most human beings. We are simply talking at what time do they cross the threshold where we make that diagnosis. And now with the concept of MCI, mild cognitive impairment, we are looking at what happened for the 5 years before they cross, where they already, like my university, Harvard University professor, clearly doesn't meet criteria for dementia, but probably has Alzheimer's pathology in his brain and is presenting with the symptom of cognitive impairment that bothers him before he meets that criteria. So, going back to cerebrovascular pathology, it can cause, it's a risk factor for Alzheimer's disease because it robs you of your cognitive reserve. If the same pathology hits certain circuits in your brain, it's also going to cause depression. And there is a concept of vascular depression that has been developed by actually Alexopoulos and his team, and a group at Duke, Stephens and his colleague, and Yvette Schiller, and it's very well established now in the geriatric psychiatry literature that vascular depression, that older people who don't have the genetic risk for depression, the family history, present with depression in their 60s, 70s, 80s because of that subtle vascular damage that damaged that circuitry that caused then depression. And so those people are going to be at risk for depression through the vascular damage and at risk for dementia through the vascular damage. You are going to find epidemiologically an association between dementia and depression. Another mechanism, and the bottom line is all those mechanisms play a role, and in the end they explain that very large number of patients who are going to present first with a depression and shortly after with a dementia. That's an interesting story because this one comes from the 80s, it comes from Johns Hopkins and from the University of Pittsburgh. People were doing brain autopsy. When I was a young student, Alzheimer's disease was a mysterious disease. If you presented to a university hospital and people thought you had Alzheimer's disease, we'd hospitalize people for a week or two. They will stay in the hospital for a couple of weeks, we'll do tests, we'll rule out a lot of things, and then after 2 weeks we'll say to the family, you know what, your mother probably has a disease called Alzheimer's disease. People have never heard about it, so that was a big medical mystery. Now, the same diagnosis, you go and see your GP, they make a brief interview with the patient, 10 minutes, talk to the family for 20 minutes, and they can sit with the family and say, you know what, I think your mother has Alzheimer's disease, and their accuracy is probably 90% plus. And when they miss, it's because it's a rarer form of dementia, but for the family, functionally, it's like Alzheimer's disease. It really doesn't make a lot of difference. By the way, people still, because it's a terrifying disease, it's a mind, don't believe you when you do that, the 30-minute diagnosis. So you say, okay, I'm going to refer you to UHN, you're going to get an MRI, people wait 4 months, 6 months, they get in a big machine for 14, make a lot of noise. What the MRI shows is nothing. There's no of tiny vascular disease, cerebrovascular disease. So the result come back, you meet again with the family, you say, no, we got the result of the MRI. And it's consistent with Alzheimer's disease, which means there's no brain tumor, there is no rarer form of dementia, there's no normal pressure hydrocephalus. And then suddenly you have done a $1,000 test. You waited a long time, people believe you. Or another way, you send them to the Sunnybrook Memory Clinic, Sandra Black with your waiting list. People wait a year. She repeats the same exam, but instead of 30 minutes in front of a GP, it's a 1 hour, 1 hour and a half. You make them come 3 times, or Memory Clinic, UHN, CAMH, St. Mike. We all have Memory Clinic, and then people believe us. But so that issue of diagnosis of Alzheimer's disease used to be very complicated. People were not really sure, so there was a lot of interest in brain autopsy. And those people at Johns Hopkins and at the University of Pittsburgh look at the brain of people who had died and clearly clinically had Alzheimer's disease. And they were able to classify the group based those who had Alzheimer's disease and earlier during the disease had depression and those who didn't. And they looked at the brain and they said the people who have an history of depression and Alzheimer's disease have more Alzheimer's disease pathology in the brainstem when you have the antinergic nuclei. You have the part of the brain that creates and project in the rest of the brain for norepinephrine and for serotonin. And they say, we believe, so they were able looking at a microscope at people who were dead to classify those who had a history of depression and those who didn't with a very decent reliability. Now it sounds like benign, but that was the first, that was before the PET scans. So that was the first evidence, okay? And again, the psychiatrists didn't believe it and were upset by that research and thought those guys were kind of odd and didn't know what they were doing. That was the first evidence that if you could say, by looking at a brain, who was depressed and who was not, that depression was a biological disease, and it was not just a psychological disease that affected mind process, which, remember, we're at a time where psychoanalysts define depression based on a variety of psychoanalytic concepts, and they were very resistant and upset that people said, no, look, if we can classify people depressed, not depressed, based on pathology, it's a biological disease. And that's what they say, well, maybe in people with Alzheimer's disease, it's just a very rare and strange disease, but it doesn't apply to younger. Then the PET came, and you can put somebody in a PET with depression and show change in their blood flow, in their frontal lobe, and after, and now we have the circuitry, and we have our colleague neurosurgeon I mean, most people now, not the general public, by the way, when you do a survey, but most people who believe in evolution believe that depression is a biological disease. Most people who don't believe in evolution, when you do a survey in the general population, there's still 30% of people who say, no, depression is a form of psychological weakness, of a sin, or you know, a problem of character. Those are the same people, if you ask them 10 questions below, do you believe in evolution, or do you believe that human beings were created as is now, they say yes. So the scientific establishment now believes that biology of depression is a biological illness. At that time they didn't, so it's interesting that one of the first evidence actually came from that field of Alzheimer's disease. And then that covered the interaction between depression and the AD neuropathology. So that's, by the way, one of those 80 studies with the locus ceruleus and the number of neurons, and you have the people who are depressed and who have lost some neuron, and the people who are not depressed. And very tedious neuron counting business, but that's the kind of study that shows that people with Alzheimer's disease and depression have strategically located brain damage compared to people with Alzheimer's disease without depression. And that's probably also one of the mechanisms. So more modern autopsy studies and find that people who have the depression at the onset of Alzheimer's disease are going to present with higher plaques and tangle in the hippocampus. Same thing, more Alzheimer's pathology in the place where you have memory, and finding that they have more rapid cognitive decline. That's not surprising. It's better to have one disease than two. Okay, that's in general in medicine. My colleague Meryl Butters has published a review where she kind of summarized all those possible mechanisms linking depression and cognition. And at the top, you have the older person with depression, normal cognition, stable over time, stay with normal cognition. You have the person with depression. The depression is associated with neuropathology, like the hippocampal volume loss. Remember the shrinking of the brain structure due to cortisol. So they are going to present with mild cognitive impairment that actually doesn't resolve with the treatment of depression, but they stay stable over time. And that's, by the way, most of our research is that in older patients, depression, even in the absence of dementia, is associated with cognitive impairment that does not revert with the treatment of depression. Then you have depression, but you also have Alzheimer's neuropathology, and including the same hippocampal volume loss. Upon treatment of depression, you present with MCI, but then you're going to progress over time to Alzheimer's disease because you have both disease. And then you have the person with cerebrovascular disease, Alzheimer's neuropathology. They have damage in those circuitry that control mood, and they have the hippocampal volume loss when you do the imaging, so they are going to present both with depression and mild cognitive impairment. You treat the depression, but the mild cognitive impairment progress toward Alzheimer's disease and the vascular dementia, and then you have the people who present with vascular disease in their brain, damage, again, some circuitry that's going to cause both depression and cognitive impairment, and going to progress toward vascular dementia. So that's a nice summary of all those mechanisms and explaining why different studies, depending of who they recruit and how they characterize them, are going to have different findings. That's because we are talking of broad syndrome with multiple mechanisms that are, it's the famous story of the blind man and the elephant. And some people see a leg, some people see dust, some people see a tail. All those studies are probably correct. They are looking at different patients recruited in different settings. And I have a slide at the end. So that's the bulk of the presentation for this group. I'm going to go relatively quickly through some slides that talk more about the clinical aspect of this. So the first issue, the clinical question. Patient present in an office of a social worker, a nurse, a psychiatrist, a GP, and the family say, is it Alzheimer's disease, is it depression? So I've already kind of talked about, you can look at symptom by symptom, and they have a different quality. There is a clinical, so the person with Alzheimer's disease, where you have that problem, often family is going to describe some apathy. She sits, she doesn't seem to be interested, the kids come to visit with the grandkid, there's a conversation, he's sitting in the back of the room, doesn't engage in the conversation. That's more an apathy issue. Or you could have agitation, fidgeting, seems anxious, move around, and agitation. The person can no longer control and make sense of the environment. You have that anxiety, agitation that has that characterization. The sound learning seems to be okay during the day. In the evening, as you lose some environmental clue, you see more confusion, more abnormal behavior. And then you have weight loss, which is part of Alzheimer's disease. People eating a bit change, they lose their appetite. You have some smoker, for instance, stop smoking. They just lose the habit of smoking. So same thing happens with the food, you have the weight loss. On the depression side, you may have a similar picture where people describe anhedonia, doesn't seem to enjoy anymore the visit of the grandchildren. The anxiety seems to be anxious, worrying about what will happen. The somatization, complain about various ailment or fear of ailment. The sleep problem also are there, but instead of the sundowning, person goes to bed at 8, seems to fall asleep. By 2 a.m. they are awake and pacing. And you see weight loss, but that's clearly due to loss of appetite. So those symptoms seem to overlap and be the same. But as I said, when you move to cognitive deficit, the typical Alzheimer's patient will minimize his or her cognitive deficit. You show obvious, you do fairly simple tests, you show obvious impairment in memory or executive function, and the guy who said, do you know who the Prime Minister is in Canada, and say, like since I retire, I don't bother with those things anymore. So with a big smile, they are not bothered. That's somebody who may have been a member of a political party, very involved. The person with depression, on the other hand, complained about cognitive impairment. That's how that Harvard professor ended up with me. He was constantly complaining to a neurologist who was tired and said, maybe it's a depression. So that's actually fairly common. For me, if you have a 72-year-old person who come and say, my brain is not working, I'm sure I have Alzheimer's disease, you do the testing, they look fairly normal, it's more likely to be depression than Alzheimer's disease. The one who complain, more likely to be depression. The one who don't complain about their cognition, more likely, but have the cognitive deficit, more likely to be Alzheimer's disease. When you do the testing, okay, the person with depression may have a low score with something simpler like you ask them, can you take 100, subtract 7 from that number, and then from 1 is left until I ask you to stop. I can, doctor, I can, it's too hard, my brain. So they get 0, or you ask them, who is the president of, who is the Prime Minister of Canada? I don't remember. They don't want to participate, they have low motivation, so they score low, but they don't answer, and I don't know, I can't. The person with Alzheimer's disease will give you, who is the Prime Minister in Canada? Pierre Elliott Trudeau. Fine, they're stuck, they're back to the 70s, and they are not at all bothered by the answer. The story, what's the month? August, what's the season? Spring. They don't. The person with Alzheimer's disease, you ask them the date, they may have, the person with dementia will give you a wrong date. Person with depression will tell you they don't know, they can't, but they're not even trying. then in Alzheimer's disease, if you look, you will usually find, even in the early stages, some subtle problem with language, or with construction. That's why people who are clinicians don't want to do 3 hours neuropsych testing, like to do the clock test. Please draw a clock with the hour showing 10 past 11, and you write this 10 past 11. You may even give them the circle. So it's not a memory test, it's a pure construction test. Patient with Alzheimer's disease, even very early in the stage, the 10 past 11, 10 is not involved, but they are going to be drawn, with one hand toward the 10. And people have looked. Any error in that clock test tend to be predictive of dementia during the following year. Normally for an 8th grader or more, somebody who has some high school, some school education, they should be able, it may not be pretty, but they should be able to do it. Any error tend to be, so fairly sensitive test. The patient with depression should be able to draw the clock. In terms of language, a very quick one to do clinically, tell me as many animals as you can think about in the next minute. It's a 1-minute test. The reason it's a good test is because it's not culturally dependent. And it's not education dependent. You could have immigrants coming from different part of the world, 3-year formal education, from 5 to 8, then started to work. Human being, that's probably an evolutionary remnant. We are all trained to recognize and identify animals. Think about in Canada, in Toronto, my kids my baby were raised here, didn't have a lot of chance to see animals, but we had a little book and we taught them how to recognize an elephant and a rhinoceros and a lamb and a chicken. I think it's part of the culture. In every Indian culture, even very urban, we go to the Riverdale and Hyde Park and we walk and show them cows. That's probably because 20,000 years ago, if you didn't know how to recognize an animal, you got killed by a predator and you wouldn't be able to eat by recognizing animals you could catch and eat. So it's still there, 20,000 years later, very developed urban society. We teach our little kid how to recognize animals. That's one of the first skills among the first few dozen of words you learn, you start to learn. So normal person in their 80s should have carried that skill. And if you ask them to, I do it with my mom, she did quite a few tests. She's a volunteer in a CAMH study. She visits me once a year and she had an MRI and she's an LC control in her study. But anyway, I've done the animal with her. And she can, if you go fast, you can do it among yourself. You can speak 20 animals in 1 minute. Okay. The norm is basically 15, and if you're 12 or below, there's probably some problem. And more importantly, if you do it enough, there's a qualitative aspect. Human being will catch the animal, you don't know it, it's unconscious. You will get to semantic category. So in your mind, you're in a farm. Rooster, cow, lamb, pig, and geese. And then you move to the circus or the zoo. Tiger or Africa, and there is a tiger and elephant, which actually there's no tiger in Africa, but in kids there's tiger, lion, elephant, they tend to be clustered together. So you split 4 or 5 in one of those categories, and then you move to the sea. Dolphin, porpoise, whales, and then you move to insect, and it's a fly or birds. So the normal human being will give you 3 or 4 semantically related, move to the next category. The Alzheimer's patient, actually, even if they still have their 12, they lose the semantic categories. And so it goes like dog, and then there's a pause of a few seconds, and then they will say koala, okay, and then there's a pause of a few seconds, and then they will say whale, and then there's a pause of a few seconds, and because they have activated dog in their brain, they will repeat the dog story. And they have forgotten, they have told you dog. Dog is activated in their brain. So if you do it enough with enough patients, very sensitive, you will find those subtle memory deficit in people with MCR and Alzheimer's disease, those subtle language, subtle construction. The patient with pure depression, even if they have cognitive impairment and executive dysfunction and cannot make decisions and are wringing their head, I don't know, doctor, if you ask them to do a clock or an animal, would be normal. If they are normal, more likely to be depression and Alzheimer's. So I mentioned this, I'm not going to show the story, but basically cognitive deficit when you do formal neuropsych testing, common, and broad-based in patients with little depression. So information processing speed, visual spatial ability, episodic memory, executive function, language, Boston naming test. You find that basically, so that's basically the person who have an impairment defined as being below the 10th percentile of the control. You can see that 40% with speed, a third with visual spatial memory and executive. Some have all of them, some have some of them. Overall, most patients with late life depression are going to be impaired. When you follow them, even when you treat, you find that they respond, but the control also improves. So that was a study done by one of my colleagues, and that showed that most of the, there was the thought that if you treat depression in older people, their cognition improved. And that based on people who have studied that group. Nobody bothered to do it with control. It's pure practice effect. The people don't understand a lot about research methodology. You have something that in every textbook, you do a simple, that's a not very expensive study, maybe $2,000 per subject, a couple $100,000. You can show that there are textbook, which have been telling something for years, which is wrong. Yes, it's true that if you treat depression, people with depression improve. You can explain 95% of the improvement to a practice effect. The gap between the depressed person and the control remain the same throughout the study. So there is they don't catch up. And that's, of course, that's a group. When you do standard deviation, there is some overlap, so some people catch up, but as a group, older people with depression, when you treat the depression, improve. Most of the improvement can be explained by practice effect. Same story that coming from the Cornell group, so showing basically even when you follow people for 12 months, you see the Hamilton scale for depression decrease. You have a minimum increase in the dementia, the Matisse dementia rating scale, executive function subscale. So they gain 1 point, they remain below the norms. I'm going to skip this one. We did publish a paper with my colleague from CAMH looking at can you use the MMSE for screening, and it's not an adequate screening instrument. And I'm going to also basically having a normal or abnormal MMSE cutoff is not predictive of who is demented or not in that population. So the last couple of slides. So now that we have talked about that overlap, and there is a large number of people who would present with Alzheimer's disease and depression, we have good treatment for depression, we don't have good treatment for dementia. Should we treat the depression? People have looked mostly at medication. The National Institute of Health in the US has funded study for the past 20 years. There is not one published study that found that antidepressants are superior to placebo in the population. And people have tried to select groups that would be more likely to show a placebo difference, which is contrary to the law. It's not that antidepressants don't work. They work very well, and there are a lot of studies showing placebo drug difference in patients without dementia. But if you take a group of patients who meet criteria for Alzheimer's disease and a major depressive episode, you randomize them to placebo or drug, and you treat them and you follow them for 3, 6, 12 months, doesn't matter. And it's not because it has not been done. There have now been several large studies, well done, multi-center, not funded by drug company, funded by the National Institute of Health in the US. They have never been able to show a placebo drug difference. So what is a clinician going to do? They are going to treat the depression with antidepressant. If you send if one of you go to a surgeon complaining of knee pain, they are going to charge you only, I promise you. If you don't want to get the surgery, don't go and see the surgeon. So if you go see a GP or geriatric psychiatrist complaining of depression, you have the symptom of depression, they are going to recommend an antidepressant. And in most of their patients, they are going to see them working. Your patient will get better. So that's why we keep doing it. We are reinforced. We don't prescribe placebo. And we don't, placebo in a research study is a very powerful, some of you have heard my lectures, so sometimes I feel I'm repeating myself, but I keep a kind of rough count. I've done more than 600 lectures over my academic career, so I repeat myself. Things don't change that much, that fast. So placebo in a research clinic is an extremely powerful treatment for depression. Here's what happened. So mom, doesn't matter if you have dementia or not, mom is depressed. She comes to our clinic at Cambridge. We meet with her. Very nice Dr. Bloomberger, physically attractive guy who is in his 30s. Meet with them, he's nice, smile, shake their hand, he's going to take care of them in his research study. You are going to come now every week for the next 12 weeks at research clinic. So your daughter is going to come, pick you up at home, so you get up in the morning, you take your shower, wash your hair, dress nicely, your daughter come at 10, she pick you up, she drive you to Cambridge for 45 minutes, find the parking, you walk from the parking to research clinic. At noon you meet attractive young Dr. Bloomberger. You spend 20 minutes talking with him, doing a questionnaire. Then you meet the nice research associate who is actually a guy who is a graduate from a program in social work at University of Toronto, spent 2-3 years doing research before he wanted to get back to do his master's. So again, attractive, dynamic, smiling, young person, a lot of social interaction. At 2 p.m. you're finished. Your daughter is going to bring you back, but now another 45 minutes of driving and talking. Because she's with you, you're going to stop at Tim Hortons, have a coffee for 30 minutes, then you're going to go to Loblaws, do your grocery, you come back home at 5 p.m. You do that once a week for 12 weeks. Excellent program for depression. And you have to, so just mobilizing an older person, getting them out of their home, spending the day with the daughter, going shopping, eating, talking to young people, talking, the questionnaire they do in the research clinic are all about their depressive symptoms. You do that, it's not surprising. Forget dementia. In the pure depressed, non-demented group, we get 40+% depression response rate to placebo, which is better than the average response rate obtained by a physician under usual care condition. That physician sees you, give you a prescription, and say, come back in 2 months in the clinic, because he knows from the study that the antidepressant take a couple of months to work. You vegetate during the next 2 months, taking your pill half of the time because you're not that motivated to take them, you're going to get 30% response rate. You get in my research clinic, you get a 40% when you get placebo. When we add the pill, if we are lucky, we get you to 60. So it's hard. Now, when you have the dementia overlap, and with creating additional diagnostic confusion, then you will never differentiate the placebo and the drug group. So, but we don't prescribe placebo. If you don't have the chance and the foresight to sign in a research study, you will be treated under usual care. The GP or the psychiatrist will give you an antidepressant and a few visits. And some people will get better, some don't. If they don't get better, they get more attention, then they eventually get better. There are people who have done study of can psychotherapy work. I had a colleague who tried to get funded to do that work and had some interesting pipe data in that population. What he found is when you have somebody who is demented and you try to do psychotherapy, during the psychotherapy session, you can affect emotion and have some benefit. The problem is, contrary to psychotherapy in younger people, there is no carryover from one session to another, so it's hard. Is that temporary improvement in emotion and in emotional process during a serious psychotherapy session, if you do that often enough, can you treat the depression? Never got the funding to do that. So it's harder to do psychotherapy with cognitively impaired people where there is no learning from one session to another. I think I'm going to stop here, but I wanted to show you, so I'm not going to show you the specific drug. That's a good slide. You can clearly see in slide 397, and you see that guy who died of PowerPoint poisoning. So that's why I want to stop here. Now we're going to go back to the questions. So you remember, in a population-based sample, a history of early onset depression increased the likelihood of dementia diagnosis more than threefold. True, false, it depends whether you're in Chicago, Rotterdam, or in Sweden. C3 is the right response. Different study of different finding. And this one is by my friend and colleague, Dr. Mary Ganguly, who is a famous epidemiologist of dementia. She has looked at a variety of studies, and she showed that in that slide that really the true epidemiology, a true population-based, looking at the older population, sample everybody. When you look at people who do research, even based on clinical epidemiology based on various samples, they get different response. Alzheimer's disease in the memory center look different from Alzheimer's disease in her study. That issue, for instance, ApoE is a very strong predictor of Alzheimer's disease in a center like Toronto Western General, George Islop, a memory clinic. Not that much in an epidemiologic sample. So when you look at depression and dementia, it's the same thing. You find different results depending on how you select your population. Is it a clinical population? And even when it's a clinical population, a dementia research clinic, a depression research clinic, a neuropsychology group will see different patients. People come and are different. So that's why it depends how the study is done and where it's done. And the question two, what do you think, if you have that conundrum about diagnosis, is the best way? So by the way, what do you think? Based on the lecture, which one would you pick? Who would pick one? Who would do neuropsychological testing to look at cognitive function? We have one taker. Who would do PET scan to see if the deficit in perfusion is the frontal lobe, showing that it's a depression, or is the temporal lobe showing that it's Alzheimer's disease? Who would do that? No taker. I've done it a few times in my career when there was a lot of, in the US you can actually get PET scan and pay for them. You wouldn't get them in Toronto unless you sign a research protocol, but they are not done clinically or refused. But in the US, where everything is for sale, an example is I saw a physician, severe depression, needed ECT, electroconvulsive therapy, in the hospital, and the family said, look, he has a practice, he has 6 employees, and he has an insurance in case he has to liquidate his practice that he can kick in. But he would rather, if he can recover and go back work and continue to make $500,000 a year and just use the insurance to keep his practice going for a few months. And so what should he do? So are you going to lay off the 6 people, retire the guy, or are you going to treat him and say we'll be back to temporary disability? Is it depression, or is it the depression that hiding a dementia? We're going to treat the depression with ECT and then mask the dementia. So here you have, and if it's the guy is 67 and could work for 7 years, you have a $5 million question. It's worthwhile spending $800 to the next CT scan, which we did in that guy, and it was a temporal low perfusion, and we said, look, you're going to get a CT, it's going to probably resolve the depression, you may feel better, but there is an underlying dementia, most likely. It's not a 100%, but it's pretty sure, and fold the practice, lay off the people, and retire. And the reason, by the way, another reason, if we had done the ECT, and then the person no longer has the depression but has a cognitive impairment, I promise you the family would be absolutely convinced my father was perfectly normal, he got depressed, was a doctor practicing, we gave him ECT, and then they fry his brain and he now has a cognitive impairment. Who would do an antidepressant treatment, saying maybe we'll respond to antidepressant and then we'll treat the depression? A couple of people. So we'll do the antidepressant treatment or in there isn't the ICT, but it won't clarify the diagnostic question. The long-term follow-up is the right answer. That's the way you will solve the issue. So if the family come and is frustrated, you remember you can do those tests, that clinical assessment, give them your hunch, and I will tell them, look, I believe, and based on the epidemiology, it's anyway more likely that we are going to be able to treat the depression, but we are going to find there's a memory problem hidden under. So I will prepare them. It's not certain. We'll still, keep the optimism going, but I will warn them. But the long-term follow-up will give you the answer. And that should give us about some time now for some questions. And I thank you very much. You've been very attentive and pleasant and engaging.
There's a question from an online viewer, and she says, can dementia lead to depressive syndrome, or is depression always a clinical precursor to dementia?
No. So I talked about depression being a precursor, but when I talk to you about those mechanisms, and in particular the autopsy study, there are also a number of people who present with dementia, memory problem, we diagnose them with Alzheimer's disease, you follow them for a couple of years, and then they develop a depression. That was not a prodrome or a precursor, but that's characteristic of the milder, earlier stage of Alzheimer's disease, where there you had a clear cut, and there's no diagnostic issue. In those studies of antidepressant in Alzheimer's disease, those are the patients they recruit. They find people who have an established diagnosis of Alzheimer's disease and develop a clear-cut depression. So they have Alzheimer's disease with memory problem and cognitive problem, and then when they stop eating, they start crying, they lose weight, their sleep is dysregulated, they may make some very negative self-deprecating comments, let me die. So, help even in later stage, you see people who are starting to lose their language ability in the nursing home and present with very, then there is no longer enough cognition to express the cognitive symptom of depression, the hopelessness, the sadness, the anhedonia, the self-disgust, the guilt feeling, but you may see some help-seeking behavior. The person who is tied up in the nursing home, help, help, help. That constantly sometimes screaming, look distressed. It is worthwhile to try to treat it as a depression. So to answer the question, there are clearly some patients who present with depression after the onset of dementia. And typically, by the way we think about it, the early stages of dementia, mild Alzheimer's disease, that's when you see the depression. Early as a prodrome or as a concurrent symptom or in the early phase. In the moderate symptom, in the moderate stage of dementia, you're going to see the patient with psychosis. That's when they start getting paranoid. My neighbor come at night in my apartment to steal my bag. They believe they are, the little lady clutching her bag, staying in her room in the nursing home. So that's when you see the paranoia. My husband is not my husband. I wake up in the middle of the night, there is a stranger in the bed. So those psychotic-like symptoms are seen in the moderate stage. In the late stage, you see the agitation. You see the agitation. There is not enough cognitive function left to express the depression or the psychosis, but you see simply then the kind of more primitive agitation. Again, I feel I'm repeating myself, and some people have heard me. What I like to explain to family about those behavioral disturbances associated with dementia is one framework that was developed by a psychiatrist from NYU in New York called Reifer. He has looked at the way people lose their ability and their stages in dementia, and he says it's like going back in time. So, I mentioned my 85-year-old mother. She's not demented. She doesn't need prior for dementia, but she's like a 14-year-old, a 15-year-old, meaning she can go, she pay her bills, she play bridge, she travels, she can take a plane, like my 14-year-old could do all those things. But she has lost the judgment she may have 20 years ago. If somebody called her on the phone, if somebody called me on the phone and wanted to sell me something, I hang up, I'm not interested. As a principal, I don't buy stuff in the phone. And if it's too good to be true, it's probably not true. So if they say, look, we have noticed you go into Europe a lot, we can say instead of paying $1,200 for a ticket for Paris, if you give us $200 on your credit card now, you can call, and it's because we sell massive amount of, that's a scam, that's very common. I know it's, I don't do it. My mother, if they were, we noticed you go to Canada to visit your family, why don't you give us $200, and all you have is to call us 30 days before the time you want to travel, and we'll sell you a ticket. And she will call in June, and there will be no ticket. So my mother could fall for a scam like that now. So that's the preclinical stage of dementia. Before you start demented, think about you go from being a 22-year-old to back being an 18 or 14. And then the next stage, when you cross the threshold, you're going to start losing ability. So for instance, an 8-year-old may be able to dress himself, herself, eat, and so on, and may do simple calculation. They go to school, copy something, stick a stamp on an envelope, but give them an envelope, a bill, a checkbook. An 8-year-old couldn't pay bills, so you start losing this. An 8-year-old can walk. You have gone 10 times to a grandparent, but if you ask them to tell you where to go, they will get lost. They still need some direction in the street. Even my 14-year-old, they're starting to go in Toronto, take the metro. I show them map. They are struggling with concepts which sound obvious to me. So you go back, so now you're 8-year-old, now go back and being 6-year-old, and you're losing more advanced, you're starting to lose your vocabulary, the judgment is gone, the calculations start to be gone, you don't, you know, that's the age, 5-year-old, 6-year-old people struggle to learn dates, day of the week, and so on. So for those of you who have kids, it's easy. Think of Alzheimer's disease as going back, and at the end, okay, at some point you're going to start to be 2-year-old. You are continent of your stools, but you're starting to be incontinent of urine. Okay? You lose, you get it in the other way. You can still walk, okay? Your balance is poor. You can no longer use utensil, but you can still feed yourself with your finger, and then your language and judgment become very circumscribed, you know, to the day. And then if you go back, the end stage of Alzheimer's disease is like being a 2 months old. You're in bed, naked, with a diaper, you can no longer even control your hand, you forget about talking, and so in those late stage of Alzheimer's disease, you're like a young kid or an adult. The only way to express your distress is going to be through agitation and behavioral disturbance. So you know, when a baby is crying, parents don't go to take a needle and give them a shot of an antipsychotic intramuscularly. First thing they do is maybe the baby is wet, they change the diaper. If it doesn't work, the mother usually feeds the kid. Maybe they are hungry and they are expressing some need. If it doesn't work, the next stage is maybe they are too hot or too cold. They adjust the environment, or maybe there is too much light or too much noise. If everything else fails, they take the baby to a pediatrician. Maybe he has ear pain and need antibiotic for an ear pain. So with an end-stage Alzheimer's patient, it's the same thing. Maybe the agitation is an expression of need. And as I said, there's a stage where people may be depressed, or it looks like depression, but they cannot express it, and you treat it between quote blindly. So anyway, long answer to a short question, but.
So I just wondered, you were talking about depression and dementia. How would anxiety be involved? Because I know that cortisol goes up with anxiety as well as depression. Are there studies that, or are those two different animals for you?
Okay, so biologically, you know, again, from an evolution perspective, anxiety and depression probably started in the same trunk, and they differentiated, and then different form of anxiety and different form of depression. But biologically, those two are related. Genetically, the risk factor for one or the other, you find them in family. They are co-traveler, they are cousins. Okay? That's the general. So most of the things that are true for depression are true for anxiety. Many people, for instance, who have general anxiety disorders through their life, when they get older, present with depression. So we have published, I have a colleague who is an expert in late life anxiety. When you look at older people with, you find that, you know, in their 20s, the person is the worried, the person anxious, generalized anxiety all of their life. And at some point, you know, here's a curve with survival. When you find those people in their 70s and their 80s, they have had almost all of them with depression. The drug that treat anxiety, the drug that treat PTSD, panic disorder, generalized anxiety, are the same drug that treat depression, same biological mechanism. So, going back to the topic of dementia, probably a lot of the things I said about depression would be true for anxiety, including the prodrome. We see it clinically. It's just there's a ton of research and a ton of researchers who focus on depression, almost nobody focusing on anxiety. But, so if you ask me, so there's no data, very few data that would be relevant to this lecture if I wanted to do anxiety and dementia. If you ask me my gut feeling, based on patients I've seen, pretty much replace the word depressive disorder by anxiety disorder, clinically significant depression by clinical significant anxiety, you will find it. And for instance, clinically, I have seen those people presenting with an anxious depression. We treat the depression, they remain anxious. The older woman, you know, the husband, he has been retired for 10 years. Every morning he gets up, was in the US, so he used to go to McDonald's. Here it will be Tim Horton, he would walk he would have a coffee and would read his newspaper. He would do that every morning and would be fine. And then his wife started to be extremely anxious as he did that. She couldn't tolerate, to the point that one day she actually attempted suicide, and that's how she found herself hospitalized. We diagnosed her with depression, we treated her as a depression, she got better, but that anxiety was still there. And then we kept following her, and at some point it became clear that she was in the early stages. So that was anxiety as a prodrome of dementia, the same way I described depression. And here, again, it's those people who can no longer control their environment. You cannot. It's terrifying. Your brain is starting to break down. You can no longer make sense of your environment. It's not surprising to me that you're going to develop that very anxiety symptom. Another thing I saw in Pittsburgh 10, 15 years ago was probably also true in Toronto. There was a whole generation of Holocaust survivors. And so those people went through the most horrible experience in World War II. There were a small number of people who survived. They immigrated to North America, so there was a community in Pittsburgh, there was one in Toronto. Never talked about it, never thought about it. They got, some of them had lost their family, their children, spouse, remarried, a new family, perfectly, fine, survivors by definition, but functioned very high level, created business, Then you found them, so that's why I'm saying now they are dead, but that's those people who were 75-year-old, 80-year-old, 15 years ago. So they, imagine born in 1910, you were 30 during the war, find yourself in North America in your 40s. We saw them in the clinic 30 years later. They were starting to develop PTSD-like symptoms, late onset, 40 years after the trauma. And then we couldn't figure out why. Why is it coming so late? And then you follow them for a few years, and you find that they meet clear criteria for dementia. So what happened, they had developed some defense mechanism to repress that anxiety, and as their brain started to, I'm sorry for the unpleasant expression, but crumble, those defense mechanisms also crumble, and so they developed those anxiety disorders that made criteria for PTSD. But normally you don't get PTSD 40 years after the trauma, and then that's because they were suffering the early stages of dementia. So that's an example of a population I saw in my clinical practice. So there is a relationship, we don't have the data.
So did I hear you say that you could treat the depression, but the anxiety would remain? And I also heard you say that the two are interlinked, and what you do for one would be do for the other.
Yeah, the same treatment, same form of therapy like CBT, same form of medication like SSRI that have been shown to be efficacious to treat depression or efficacious to treat the anxiety disorders. So the treatment is the same. What I tell you is clinically, the harder form of depression to treat is the very anxious depression. The patient who is very psychomotor retarded, sit in the chair, that picture. I didn't take any, it's blocked, so that's okay. You remember the picture, the guy sitting? Okay. So, so at the end. So that guy, by the way, you find him in the cartoon from the 1950s, it's a New Yorker, okay? Which is the same guy that the naturalistic painter, the same guy that the cartoonist captured, this guy. So that's German naturalistic painter, late 19th century. Cartoon in the New York Times, New Yorker, 60 years later, same guy. So those artists, those cartoonists, the stoop posture, sitting there, not moving. Here you have the concerned children, and you have the physician, and the caption say, when in need is a change of scene, why don't you move into some other window? And I show that cartoon to show you the misunderstanding of late-life depression, as if it's a joke. Like, dad is sitting looking at a brick wall, literally. There's a brick wall through the window, not moving, and so that retarded depression responds very well to treatment. The other guy, by the way, is wringing his hand. You're going to treat the depression, you will be stuck with anxiety. That's the hardest form of depression to treat. It's not as dramatic because that guy is not moving, not eating, sicker than the anxious depression. Oh my God! And for some people, by the way, it goes all the way to what we call psychotic depression. The anxiety is so overwhelming that it becomes a delusion, a fixed belief. And those patients with anxious depression and psychosis, psychotic depression with delusion, do not respond that well to antidepressant. They end up getting ECT, or they end up getting a combination of antidepressant and antipsychotic.
Thank you.
Any other question, comment?
Can I ask?
Sure.
Do you think family history or genetic influences has something to do with the depression and later
So
on?
there is very strong evidence that mood disorder, depression, bipolar disorder, anxiety disorder are genetically determined, and yes, they run into family.
So they do.
So now, genes are not destiny, meaning there are people who have the genetic risk and don't develop the disease, and human beings have the capacity to be depressed or anxious, even in the absence of genetic risk. Anybody in this room, our brain has been created through evolution to the point that if you have a stressor that's bad enough, any of you in this room can get depressed. But there are people who get depressed with stressors that are much smaller, or things that are stressor for them and would be a happy occasion for most other human beings, like moving to a nicer, bigger house, getting a promotion. People don't think of those things as stressor because they are happy events. We all wish they would happen. For some people with the genetic risk, those things are stressful enough that they develop depression. Some people who get recurrent depression at some point start to get depression without any stressor. They come and say, you know, I was fine last week and I started to feel that awful feeling. It's almost like a switch. So yes, you find genetic risks in that group of patients. And then you ask them, and they have an uncle who hanged himself, a grandparent who was in a sanatorium, a brother who is being treated with psychotherapy, a cousin who is an alcoholic. So yes, you find family history. There's a lot of research, strong genetic component, but it's not destiny. Your people of the family history don't get it. Some people who don't have the family history who get it. I say you take one of your children, you put them in front of a truck. Most normal parents will go through a depression lasting between not just grief, depression, with physical symptoms, 3 months to a couple of years. Some people never recover. It's an example of a major stressor. So, you get fired. Most people go through. You get nasty social conflicts at work resulting of loss of job. It's another stressor. So that, and by the way, when I say we have been, the reason those exist is because, from an evolutionary perspective, there may be advantages. It's what's disadvantageous is a severe depression that's incapacitating. Some level of depression that stop you from expanding resources, to lead to what the expression banging your head against the wall. So the social conflicts model of depression, withdrawing, admitting defeat, stopping to fight it, may be in the long term a good strategy, rather than defying your boss and getting fired. You get depressed, you submit, maybe your boss gets fired and then you get his job one day. So from an evolutionary perspective, those, the capacity to get depressed or to get anxious, if you get anxious, you don't like open space, and you prefer to stay close to trees, you're less likely to be eaten by a lion. You can run back to the tree. The people who love to explore dark space without light get eaten by bear and lion, and they don't reproduce. And so we're all the descendant of people who were afraid of those things. For most of us, it's something that's controllable, and it's actually protective. People who love to go on cliff and do that, well, some of them fall. Okay? So most of us don't like it. But we can go to the CN Tower and we can take an elevator. Some people, it's the real stuff for genetic reasons. So it's a bell curve. If you're right there, you have the right level of anxiety that's protective. If you are here, you get sick and you need treatment. If you are here, you don't go and see a psychiatrist saying, I don't get depressed or I don't get anxious enough. You know what happened? You end up in a cemetery or a jail. See, the people who love to drive 200 kilometers an hour and run red light, they get killed. Or people who don't, I couldn't attack a bank, I would be shaking. If I could get a gun, go and stick a bank, there are people, they don't shake, they feel perfectly fine, they have no anxiety system. They find themselves in a jail or in a cemetery. So the point is, people think of those diseases as disease. There is an aspect of them that's actually a defense. Like people who have no pain system for genetic reason keep hurting themselves, get infected, die. Having pain is useful. If you have too much pain, it becomes a disease and you need to be treated. So when you think of depression and anxiety, you have to think of them in the context of evolved mechanism that to some degree are useful. What we call the disease is the right of the bell curve when you have too much of it and it's disabling, and those people need to be treated like we treat people with chronic pain. But it's useful that if I bang against that table, I will have pain. If I don't, I will keep banging myself and sticking needle and spine in my feet. I'll get infected, I'll die. Anyway, on that very high-level comment, it may be a good, good food for thought. Thank you again, and good luck in your
Yeah.
practice and professional activities.
Thank you.